It's the appointed time and we have a quorum. Welcome to this meeting of the Subcommittee on Matters Relating to the Development of Smart City. Let's invite the administration and the hospital authority to come in. Item 1 on the agenda, updates on implementation of smart health. The paper has been sent to all of you. With those who'd like to put questions, please press the button. Welcome, Undersecretary for Health, Dr. Libby Lee and her team. We also have representatives from the Hospital Authority, Dr. Chung Ai-chen and his team. We also have representative from the Digital Policy Office, Deputy Commissioner Daniel. We also have Principal Assistant Secretary for Innovation, Technology and Industry here. Perhaps I first ask the administration to make an opening remarks. Undersecretary, thank you. Chair and members, with the aging population and the declining labor force, members of the public have increasing demand for health care. The situation is the same across the world. With the imbalanced demand and supply, we should make use of IT to meet the gap and meet the expectations for quality health care among members of the public. Smart health is the direction to take. The government has always adopted this people-centric principle to transform our smart health initiative, and we have incorporated this into our Hong Kong Smart City Blueprint. We want to achieve 5 different goals. By adopting IT, we want to enhance the efficiency of the systems. Second, improve the quality. Third, we want to enhance patients' experience. Fourth, we want to enhance government capabilities in meeting demand for public health, and we want to promote medical innovations. I will talk about the latest progress of the government in 4 different areas. First, I'd like to talk about how e-health promote smart health in Hong Kong. In 2016, the government rolled out e-health. We want to enhance people's experience when they seek healthcare services. Across the territory, there are about 6 million people who have registered an account under e-health that cover 80% of the population. We have accumulated some 4.2 billion healthcare records. With the e-health development in the 2023 policy address, we announced this 5-year plan of e-health to upgrade e-health from a health record sharing system into a comprehensive healthcare information infrastructures that integrate multiple functions of data sharing, service delivery, and care journey management. We want to link up different sectors and tiers of the healthcare system and create a smart health ecosystem. E+Health will facilitate care coordination, cross-sector collaboration, as well as active health management and surveillance, thereby better serve our citizens in obtaining optimal healthcare service and support various healthcare policies more effectively, such as primary healthcare and cross-boundary healthcare. We are taking forward e-health plus development progressively. In July this year, we rolled out a e-health plus app and the functions of cross-boundary health records as well as personal folder. This facilitates members of the public to make use of the e-health application and the usage of elderly healthcare vouchers. Under the e-health application, we want to consolidate primary healthcare functions. We will provide community pharmacies based on the one family doctor per person. For citizens participating in the chronic disease co-care pilot scheme, they can use e-health platform to manage their family doctors pairing at DHC's arrange allied health and laboratory services. People can also manage related services and documentations, such as reserved DHC services and access laboratory required under the scheme. Now, in terms of digital transformation of public healthcare services, develop smart hospitals and provide smart care are one of our development strategies. The hospital authorities has always adopted advanced technology and AI to improve the services. We have introduced smart hospitals, smart clinic, and smart ward. Through digitalizing the service and automation, we want to enhance operational efficiency. We already have 20 smart hospital products in all hospitals. We expect that all key smart products will be in place in all hospital authority hospitals by the first quarter of 2025. We will also provide clinical diagnosis by AI and provide remote hearing or telehealth to improve our service quality and to meet the increasing demand for healthcare services. Third, digital transformation of public health protection and regulatory control. In 2018, HA formulated the strategy plan to re-engineer and transform public services. In 2019, we established the Health Informatics and Technology Office to advance our IT enhancement and digitalization tasks. We are rolling out different projects. For example, the shared licensing and monitoring system to integrate the systems of all regulatory units through a central data repository to enhance our operational efficiency. We will continue to promote the linkage of e-health and IT systems. Lastly, on promotion of medical innovations, we will adopt institutional innovations and systemic innovations. We want to enhance our clinical capability and promote transformation of R&D outcome. We have a Greater Bay Area clinical trial collaboration platform, and we will also establish a real-world study and application center to support clinical diagnosis and treatment, new drug development, and public health. We also want to promote a development of new drug and turn ourselves into an international medical innovation hub. That's all for my presentation. I welcome questions and comments from members. Thank you. Thank you, Undersecretary. Hospital Authority? Nothing? Okay. We have 8 members who have pressed the button, including myself, 9. Mr. Tang Fei, Mr. Chan Shenying, Mr. Chan Xiuhong, Ms. Carmen Khan, Mr. Andrew Lam, Mr. Ma Feng Kwok, Mr. Duncan Chu, Mr. Dennis Lang. Each member will have 5 minutes, including question and answer. Mr. Tang Fei. Thank you, Chair. I have 3 questions. They are rather technical. I don't have any policy questions. I'm glad to see that there is a function of cross-boundary health records under the e-health application. So are we providing such functions for the hospitals that use health vouchers? Even for hospitals that cannot or do not accept health vouchers, as long as they recognize our diagnosis and health records, that would be all right. I believe that patients will be able to use the e-health platform in the mainland. Some members of the public may purchase mainland SIM cards on the mainland. Will they be able to access the e-health platform by using the mainland SIM cards? Second, in paragraph 15 of the paper, I'd like to seek clarification. It is said that members of the public can self-input health data such as blood pressure, blood sugar, and body mass index. I'd like to ask about authorization. Senior citizens may wear medical wearables to monitor their blood pressure. Can they input the health data on their own? Because there could be discrepancy between those taken by the doctors or medical practitioners and the patients themselves. People may purchase medical devices to track their own metrics and input them into the portal. So I'd like to ask if the medical data will be accepted. In paragraph 16, it is said that in 2025-26, the e-medical certificate e-identification will be rolled out on the e-health application. Can you explain what these are? What kind of certificate are we referring to? By e-imaging, are we talking about facial image or MRI or CT images? What kind of image are we referring to? Thank you. Undersecretary. Thank you, Mr. Tang. Regarding e-health plus, I will ask Mr. Hui, Deputy Secretary, to answer. Well, regarding the self-input health data, we want to transform eHealth Plus into a health account of the people. It would be best if the people can input their blood pressure into their account, and if they're wearing blood pressure measuring devices, sometimes it can be, well, the data can be sent to their mobile phones automatically. That's just only for reference for the doctors. When we look at blood pressure and blood sugar, we look at the trend. We just want to know the relevant data in the day-to-day life of the people. As to whether people can use e-medical certificate and e-health plus while using mainland SIM cards, I will ask Mr. Hui to answer the question. Thank you. It would be fine and okay for people to access e-health plus by using mainland SIM cards. But mainland medical practitioners and doctors should not just rely on the patient's mobile phone to look at their records. We want to connect medical health or healthcare data in the back-end systems so that the medical practitioners and doctors can access the healthcare records on their own computer. In that case, the information and data will be more accurate and reliable. And we are working things out with the mainland hospitals and medical institutions. So we want to promote connection of medical data across boundary. As mentioned by the Undersecretary, for data input by patients and members of the public, well, patients are the one responsible for managing their own data. But the data is of a certain reference value for the doctors. For blood pressure, blood sugar, if patients record their own level, then that will facilitate the doctor's understanding of the patient's conditions, and that will facilitate diagnosis. But then, of course, we have to ultimately rely on the doctor's judgment. They don't have to completely rely on the data input by the patients, because the record is just recorded at a day-to-day life scenario, not under clinical conditions. Through wearable medical devices, patients may send healthcare data to their application so that members of the public don't have to input the data on their own manually. Lastly, about e-imaging. By imaging, we're not talking about facial image, but radioactive images, including CT and MRI. Thank you.
The speaker's microphone is not on. Next, Mr. Chen Ying. Thank you, Chair. I do note there are 4 development directions in e-health system. One of them would be One Health Record. It is said that 6 million and citizens and 400 healthcare practitioners are participating in the system. However, that would mean 80% of healthcare professionals and 1 million citizens have yet to participate in the system. Are there any more incentives to encourage citizens and healthcare professionals to take part in the system? There are initiatives to encourage healthcare professionals to do that or even mandate them to do that. For private healthcare professionals in particular, will you try to resolve the technical difficulties in uploading their healthcare records onto the system? I think there is a duplication with the functions of HAGO and eHealth. There should be a seamless interfacing later on. The 2 apps are independent at the moment. This is like I Am Smart before, because when you have to access the functions of the IRD, for example, one had to log in again. I think this is what we're seeing with HAGO and eHealth system. Right now, I Am Smart do not require repeated logins to access specific departments' functions. It is now much more convenient. Is this the direction that the Health Bureau is going to take in future? It is a trend to make good use of technologies. You have talked about 5 robotic technologies being used to alleviate manpower shortage. I do understand that there is a type of companion robots. I'm not sure where this is to be used. Is this going to be used for children or elderly patients? Will these robots provide entertainment, or would they provide, say, psychological counseling? Thank you. Undersecretary, on eHealth Plus, I'll let Mr. He answer that question. On companion robots, I'll let Dr. Lee answer the question. All right, Mr. He? With the registration of eHealth Plus users, we have over 6 million citizens that have registered. So that is approximately 80% of the population. For adults, we have almost full coverage. What is left now is children. The group that is lagging behind is children, and they cannot register for eHealth themselves. So that's why we are promoting to parents that children should register for eHealth so that they can make good use of public health services through eHealth, such as immunization. With their registration on eHealth, this should foster the habit of maintaining health and nutrition records of children. In future, they will then become active users of eHealth. That's what we're trying to do. On healthcare professionals, we have over 80% of healthcare professionals have registered on eHealth, and they are using eHealth at the moment. Unfortunately, we do not have as many private healthcare professionals uploading health records onto the system, as the member said. We have implemented a number of pilot schemes in recent years, and we have seen good results. We are trying to devise technical solutions to facilitate private healthcare professionals' use of eHealth to upload citizens' health records onto the system. Having resolved the technical difficulties, we will make good use of different schemes, or perhaps even legislation, to promote the use of eHealth by private healthcare professionals and upload health records onto the system. As for the relationship between HA Go and eHealth, our direction is clear. We want to have no overlapping in functions. We do see people having to jump between the two applications for certain functions. That is not ideal. In future, we will have some core functions of eHealth moved from HA Go to eHealth, but it does not mean HA Go will be eliminated, because HA Go functions are relevant to public hospital setting, at least some of them. For example, dispensing, and some of such should be kept in HA Go. But as a record platform, these functions will be moved to eHealth. Yes, Dr. Lee. We have over 30 hospitals, and they employ 359 robots. One of the types of robots would be companion robots. They would provide support. Apart from using it in geriatric wards, we also use this in psychiatric wards. Apart from providing companionship, they would prevent certain incidents from happening. The robots can issue reminders. They also have other functions. They can measure body temperatures of patients. They can also disseminate information in wards. Thank you. Mr. Chen Xiu-hong. Thank you, Chair. I first would like to praise the efforts of the hospital authority as well as the HRTO Health Informatics and Technology Office. Yesterday, a few of us visited the Chen Kuan O Hospital. Unfortunately, I was not able to attend because I had to attend a meeting of the Public Works Subcommittee. I heard from members they did see much effort being put into the hospital incorporating smart elements. I hope that the hospital authority will continue with their efforts, but we should also be prudent because there are always risks associated with the use of technology. Due to time constraints, I have more than 2 questions, but I'm just going to ask 2 of them. On health records, it says that in September, approximately 400 healthcare professionals private healthcare professionals have connected to the eHealth system. And in paragraph 10, there is a pilot scheme. Is that the pilot scheme back in 2023? Yes. Mr. Ho. In 2023, we did have a pilot scheme. In 2024, we have another pilot scheme. To work with some eHealth care record systems or practitioners to promote interfacing of systems. The target is to provide a one care journey. So private healthcare practitioners can just make use of the systems they have been using, and that system will be connected in backend to the eHealth system. So the 400 private medical practitioners, through such connections to the system, can automatically deposit health records on the eHealth system. This is different from the pilot scheme in 2023 that encouraged private healthcare practitioners to upload health records onto the eHealth system. This is a step forward and an advance in technology. Okay, I do see in February of this year, the panel on health services discussed this topic. It is expected that at the end of first quarter 2024, approximately 500 healthcare practitioners would be connected to the e-health system. We are now in the third quarter. We only see approximately 400 healthcare practitioners doing that. There is a gap. The government said there are several barriers. It may be due to some difficulties in the use of the electronic system, but I also understand that some private practitioners are not interested in doing that because the patients can then move and shop around for different doctors with their records. So they would keep most of their data within their systems or their groups. I do understand they have their commercial considerations, but for the benefit of citizens, would the government have any incentives to promote the use of e-health system among private healthcare professionals? We have to ensure there is portability and mobility of citizens' health data. Thank you. Undersecretary. What the member said was quite correct, but then we have always emphasized also that the data of patients belong to themselves, and if they have to go to another doctor, our system should facilitate that. That is the access of health records of the citizen by other healthcare practitioners. We have different incentives on this. For government projects, we do mandate practitioners to be connected to the e-health system. For example, the chronic disease co-care program, the data would be deposited automatically onto the e-health system. We will also explore the possibility of mandating certain data being deposited in the healthcare system. Well, let me say this. It would be very clear to see whether private groups have participated in the scheme. And in fact, I have observed the operations of private healthcare groups. When they have to connect to the system, they need incentives. I urge the government to provide incentives for private healthcare professionals to be connected to the system, not only in uploading, but also in promoting the portability of such data. Thank you, Ms. Kamen Khan. Thank you, Chair. I would like to first praise the efforts of the Health Bureau as well as the Hospital Authority in promoting smart health. On promoting cross-boundary health collaboration, I'm happy to hear that in September there are 3 new trial points for the elderly healthcare voucher scheme in the Greater Bay Area. The foundation for this is to have the cross-boundary health record and personal folder functions so that patients can make use of such functions after they have activated the cross-boundary health record function. But then this function can only be used in the designated hospitals, correct? After they have gone to doctors in the mainland, they can deposit the health data in their personal folder, and such data can be accessed by local practitioners, right? I believe that's how it works at the moment. I want to ask, what is going to be the future policy direction? Are we going to have more designated hospitals? Or is it possible that we can work with the Guangdong Provincial Authority, the health commissions, so that we can promote interfacing? If necessary, we may need to interface our legislative frameworks. Now, I also appreciate that there should be amendments to the electronic health record sharing ordinance. As the Undersecretary said, the possession of patients' data is a right of patients. I do appreciate the 4-1 initiatives and directions. And I think we need to involve more private healthcare professionals, but I also understand that they may be resistant to this. What is important is patients' rights to access of data. We need to consult stakeholders to see how we can do this. And I understand that before they talked about data on allergies, dispensing, as well as medical laboratory reports. If we can break the barrier between public and private healthcare practitioners, that would be ideal. And I understand, however, when you consult stakeholders, there may be differing opinions. Yesterday, we visited the Chen Kuan O Hospital. I thank the hospital authority staff for giving us some introductions to the facilities of the hospital. Yesterday, I actually suggested to the hospital authority that the system should be connected to IM Smart. The IM Smart system should act as a foundation for the hospital system so that one does not have to log in again when accessing HAGO. Even if people forget the password on HAGO, it would be the case that they can still access the data on eHealth.
Thank you. Undersecretary. Let me first respond to the question on the legal framework. I thank Ms. Khan for her support. We are consulting the trade, but as the data belongs to the citizens, we ask the medical practitioners to upload their information onto the eHealth Plus platform. As for cross-boundary healthcare records, fortunately, we have a holistic system to take care of all the healthcare records. But in the mainland, individual hospitals has their own system. So we have to link our application with each and every hospital on the mainland. Hopefully, over the long run, we can work with more hospitals in provinces. I will ask Mr. Mr. Hui and Dr. Chen to supplement. Who is going to answer the question? Mr. Hui? Thank you, Chair, and thank you, Ms. Khan. Let me supplement. Now, in terms of cross-boundary connection, for users of elderly healthcare vouchers, their records are available on the mainland. This is just a pilot scheme. As mentioned by Ms. Khan, in the future, we will amend the Electronic Health Record Sharing System Ordinance. And under the ordinance, we will set out legal framework for cross-boundary sharing of health record. In the future, we will be able to designate a medical practitioners outside Hong Kong. We refer to the systems instead of the locations. We may designate some hospitals as the users of eHealth. Hopefully, in the future, with the digitalization of health records on the mainland, as mentioned by the Undersecretary, we now use hospital as the basis. But I know that various mainland hospitals is developing e-health record systems on a district basis. We will allow the connection of systems in the future upon amendment of the ordinance. Dr. Chang?
Excuse me. So yes, we certainly agree that IM Smart is a very good way to make it easier for citizens to get to the functions of HAGO. And so we've already, for instance, used it for certain functions. It already works. IM Smart allows you to log into HAGO. You can activate and register through IM Smart. And we're looking at, for instance, you mentioned the very good point about the reset of password. That's something we're doing in the coming months. So we're looking at all these issues where IM Smart can make the HA Go experience better. We're certainly looking at these, and we hope to have more of those in place in the coming months.
Thank you.
好，跟住下一位林少。
Thank you, Mr. Andrew Lam. I have two questions on the cross-boundary medical collaboration. First, I support the functions of cross-boundary health records and the personal folder. I know that you have designated institutions under the systems. We have residential care homes in the mainland that participate in the Guangdong scheme and Fujian scheme. Will you extend the arrangement to those residential care homes for dentists and physiotherapists? People are seeking such services on the mainland. Now we target Hong Kong registered medical institutions, but over the long run, will you consider including such services under your arrangements? If you do have such a plan, what is the challenges? And what is your consideration? That's my first set of questions. Second, on the usage of elderly healthcare voucher, as we expand our scope of service to dentists and allied health services, what are the challenges that you face? How can we make use of technology to track and monitor? My next question on medical innovation. In paragraph 42, you set out the framework, and I fully support it, especially with the measure of Hong Kong registered drugs and medical devices used in Hong Kong public hospitals in the Greater Bay Area. But I'd like to know about, say, the central database creation. What is the roadmap and schedule for the creation of such a database? What will we see in the coming 1 to 2 years, for example? Thank you, Chair. Under Secretary, I will first ask Mr. Hui to talk about eHealth Plus and the elderly healthcare vouchers, and then I will talk about medical innovations. Mr. Hui, please. Thank you. Now, in terms of cross-boundary healthcare collaboration, we've talked to the Labor and Welfare Bureau. I know that a lot of senior citizens are retiring on the mainland with the support of policies and measures under the LWB. RCHEs have their own arrangements, but in most of the cases, they collaborate with hospitals in the neighborhood to provide healthcare services to the retirees. If the systems in those hospitals are suitable, we may connect it with the eHealth application. But the discussion is just at a very initial stage. We allow, however, such possibility under a framework. Mr. Lam, you also asked about what the challenges we face on cross-boundary collaboration. First of all, there are technical challenges. That is to say, the data format is different between Hong Kong and the mainland. Also, the language and the professional requirements of healthcare records is also different. So we have to make adjustment. We cannot connect after all the healthcare records have been standardized. We may not have to align everything before we connect the healthcare records. We want to facilitate the mainland medical practitioners to be able to browse the patient's records in order to make diagnosis. Second, legal framework and regulations. Well, in Hong Kong, we have an ordinance to monitor and regulate the sharing of health records. Under the ordinance, we protect the data of the people, and we also have to ensure the security and comprehensiveness of the system. These are the things that we abide by. But when we open the system to systems outside Hong Kong, we have to ensure that our system's security and privacy will not be undermined. So apart from system connection, we also have to align our regulations. Undersecretary, thank you. On medical innovations. Now, on the transformation of hospital systems, we have to initiate institutional innovations. When we create a new drug and new equipment, we have to go through clinical study. Last week, we worked with the Greater Bay Area and established a Greater Bay Area clinical trial institution. That's a collaboration between Hong Kong and Shenzhen. In the Greater Bay Area, we have 86 million people. That will facilitate our effort in this regard. When the drug and equipment is to be registered, the institutions will have to look at how the drug and equipment are being used in real world. So we will be establishing a real world study and application center. Hopefully, in 2025, the center will be commissioned. Why do we enjoy an advantage on this front? That's because under the Hospital Authority, over the 29 years, we have 43 hospitals with different forms of records. Overall, we have 15 million patients' records to provide real-world data for central data collections and clinical study. That will facilitate the registration of new drugs and medical devices. Thank you. Next, Mr. Ma Fung Kwok. Thank you, Chair. I am a user of the e-health. I felt good about the platform, and I commend the Hospital Authority for it. But as mentioned by other colleagues, the private and public healthcare records are not connected. Can we provide incentives? On the technical front, I wonder if the HA has considered opening up part of their systems for private medical practitioners so that they can connect their systems with that of the hospital authorities. They may need additional resources to do that, including technical, manpower, and financial resources. If we can provide such incentives for the private medical practitioners, we may help them overcome their difficulties. Second, on cross-boundary health and data sharing systems, I wonder if the administration has a roadmap. Are we going to expand the collaboration to Shenzhen and then to the Greater Bay Area? Is there a timeline? Third, now we compare ourselves with other places in terms of the development of smart city. Compared with Seoul, Shenzhen, and Singapore, in terms of smart tourism, it seems that we're lagging behind. Do we have any plan to compare ourselves with our neighboring cities in terms of the development of smart health so that we know what we should do? Undersecretary.
Thank you. On the question of eHealth Plus, I'll let Mr. Ho answer that question. As for the question about comparing ourselves to other regions, I'll answer that last. Mr. Ho. Thank you. At the early stage of developing eHealth, In fact, e-health was developed by the hospital authority as well. We were going to open a block of the system for private healthcare professionals to input data. We later found that to be not feasible because many private healthcare practitioners use their own clinical systems. In fact, 70 to 80% of private medical practitioners make use of their own systems to manage their clinic operations. If we ask them to input data not only in their own systems but also the HA system, many of the medical practitioners were not willing to do that because that was cumbersome. So we took another direction. We would not require medical practitioners to input repeatedly patients' records. Instead, we are trying to seek connection in the back end between the systems so that while medical practitioners are managing their clinical operations with their own systems, their data will be automatically uploaded to the hospital authority system as well. This would facilitate the medical practitioners' use while also achieving our goal. We, of course, need to offer incentives for private healthcare professionals to deposit health records of citizens into e-health. We have done so through government subsidies. In future, we may amend legislation to achieve this. In future, once we have had further interfacing of the systems, we would launch a certification scheme for private healthcare practitioners to show how committed private healthcare practitioners are to the e-health system. If they have deposited much data, they may receive a gold award. If not, perhaps only a bronze certification, so that citizens would know how much of their data will be deposited by the private healthcare practitioners onto e-health. I hope that is going to help medical practitioners do that in future. Yes, Undersecretary. With the use of technologies, not only in the back end but also in clinical services, so that we can achieve precision medicine to provide personalized healthcare services. One part of it would be electronic health records. The hospital authority has done really well. In July, they have received an international award from the HIMSS Healthcare Information and Management Systems Society, the EMRAM Electronic Medical Record Adoption Model Stage 7 maturity level. That is the highest maturity level. Our healthcare system, especially in biomedicine, is quite advanced compared to the rest of the world. We are ranked the top 2% in the world in R&D in medicine research. In hospital operations, we are exploring the possibility of incorporating more technologies. Thank you. Excuse me, they haven't answered my question about cross-boundary healthcare collaboration. Mr. Ho. Thank you. Well, we are taking two directions. One, as announced in the policy address, we are trying to make sure elderly healthcare vouchers can be used in all mainland cities in the GBA. So we are looking into expanding the coverage of such vouchers. So that's with the breadth of development. On the depth of development, we are looking into enhancing portability of health records of patients on both sides. This is a starting point, but this is not ideal in the long term. We do admit that. When the timing is right, we hope that with designated institutions, there can be interfacing between the systems so that some advanced data can be transferred between the two sides. That is what we are looking to do in the future. For institutions that are already covered under the elderly healthcare voucher in Greater Bay Area scheme, we have some Shenzhen dental clinics that are not covered by this at the moment, while being designated institutions. So we are trying to plug the hole here. Thank you. Mr. Duncan Chu, let me also say I first declare that I'm a board member of the Hospital Authority. I am also a member of an INT committee for the Hospital Authority, as well as board members for 2 hospitals. I have participated in many technological initiatives of the Hospital Authority. Being a part of this, know that the Hospital Authority has done much, and they should be proud of this. There are always difficulties with the promotion of the use of technology. We should think about our vision when promoting the use of technology that is to benefit patients. We have been promoting the uploading of health records of citizens, and such health records should also include lifestyle habits of citizens. But the problem is, we do not have many private healthcare professionals uploading data onto eHealth. We had a number of pilot schemes. We had also the DHC's, the various incentives that would promote the use of eHealth by private healthcare professionals. Unfortunately, I think the most effective way would be amending legislation. This was mentioned in this year's policy address again. So I want to ask, what is the timeline for amending legislation in order to actually make private healthcare professionals upload data onto eHealth? But before you actually amend legislation, we have to make sure all technical difficulties are resolved. Some doctors in clinics, while being connected to eHealth, are required to input data repeatedly still. And some have asked if it is possible to exclude footnotes that are on their systems from being uploaded to eHealth. I think we need to iron out these issues before amending legislation so that private healthcare professionals can conveniently and operationally feasible it will be operationally feasible for them to upload data onto eHealth. Thank you. Undersecretary. Well, we plan to start the legislative amendment exercise in the first quarter of next year. For the rest of the questions, I'll let Mr. He answer them. Thank you, Mr. Chu. I'm sure you're very familiar with the work of the use of technology in the hospital authority as well as the health bureau. We are actively preparing for the legislative amendments for electronic health record sharing. At the moment, we have the Secretary for Health empowered to specify in law what kinds of data, when and where such data should be uploaded. While we do plan on amending the legislative framework, we have to think about what kinds of data upload should be mandated. It is because, as Mr. Chu said, while we have done a lot to facilitate connections between private medical practitioner systems with the HA's system, there are still some technical issues. On the premise of such technical issues being ironed out, the Secretary for Health will exercise his power to mandate private medical practitioners to upload health records onto eHealth. As for the procedures for uploading, we will have some requirements imposed. We will also provide defenses if the practitioners need more time or require exemptions, depending on how reasonable the justifications are. We should have the flexibility to accommodate that. But in future, the goal is clear. We will mandate the uploading of health records by private healthcare professionals onto eHealth. If private healthcare professionals indeed have difficulty, we hope to iron out these issues through communication with the private healthcare professionals. Thank you. Mr. Dennis Leung. Thank you. I've observed in the past few years the hospital authority and the government in general for HA Go and I Am Smart, as well as eHealth and eHealth Plus. They have done much to enhance their systems' capabilities. But the point is, we should make it convenient for the users, that is, the citizens, to use the systems. For example, in HA Go, there is a new function for my carer or my relative. This is a good function because whenever a relative of mine has to go to ENT, psychiatric, or the psychiatry department, or gynecology department, and so on, I will know. But the problem is, right now we not only have patients going to the doctors, we would also have the carers going to the doctors. The approach taken by the hospital authority right now is not very people-centric. When a time slot is allotted, it cannot be changed. And most carers, if they have to work, they would prefer something early morning so that they can go to work afterwards. Not only would that affect them personally, it is not good for social productivity. If you have a function that can show and allow people to change their booking times, then that would be what people would consider smart. If you have to rely on staff members telling patients what is the availability of certain medical practitioners, it is not smart. And I think with the Department of Psychiatry, often they would have to have patients or carers submit documents to medical practitioners in paper copies. If you would allow advanced uploads of such documents, that will also prevent cross-infection. It is safer, it's more hygienic. It will also be more efficient and convenient. Is it possible for you to have functions that would be more people-centric, that people will find beneficial in the use of the system? Thank you.
Undersecretary. Thank you, Chair. Thank you, Mr. Leung. Your suggestions are great, and we need these ideas in order to improve our system. I will ask Dr. Chen to answer how we can tackle these issues.
First of all, thank you for that reminder that ultimately we are trying to make healthcare better for the citizens and their families. So I think that's a key point. And that's exactly why the whole carer concept was implemented in the first place. So with regards to specifically your question about outpatient appointments, and we do know that this is a pain point. So for instance, we've already within HAGO already added the ability for you to change your appointment. So you can through the app now say, oh, I need to change the appointment. It doesn't actually allow you to specifically say exactly what time you want. That's still something we have to work on. But another thing we have done is now in the first when the appointment's being given, we're now looking at a wider picture of the patient. They might have multiple specialties, that sort of stuff, and trying to align it so that at least we can sort of simplify the schedule for the patient. So that's some work we're doing there. In terms of your last point, that's something actually we are now working on. How can we, before the patient comes in for their appointment or before their visit, is there some information they can provide? And so you mentioned certain documents. There could be some questions that the doctor routinely might ask, so maybe the patient could just fill in those things beforehand, simplify that process, so when they actually see the doctor, it's already in the record, and it's much easier. So I think we're certainly looking at some of the ideas you talked about, and hopefully we'll be implementing more of those in the near future. Thank you.
Thank you.
好，跟住下一位係陸漢文議員。
Mr. Benson Luck. Thank you. Now, by upgrading eHealth to eHealth Plus, that will promote public health and facilitate our development into a smart city. That's a milestone. $1.4 billion have to be spent on the development of eHealth Plus, while the cost per capita is just some $200. I hope that the administration will work on improving the platform. I'd like to talk about eHealth. In paragraph 6, it is said that we have 6 million eHealth registrants currently. The goal of eHealth is to cover diagnosis and eHealth records. That's also a tool to help citizens build a healthy lifestyle. We should prevent instead of focusing on cure, and we should promote healthy living. In paragraph 17 of the paper, it is said that in September 2024, a new eHealth or E Plus Life Health Challenge platform has been launched under eHealth to promote a healthy lifestyle. I support the initiative, but the E Plus Life is on another application that is outside eHealth application. We have a lot of mobile applications. Why are you hosting E Plus Live on another application instead of putting it inside the eHealth application? People embrace healthy living these days. If we can integrate these two concepts into a single application, that will facilitate the promotion of healthy lifestyle so that we don't have to promote two different applications. Now the E Plus Life has been here for 2 months. Is the download rate satisfactory? We want to help people adopt a healthier lifestyle, and I've looked at the application. And I have started some new programs. It seems that the platform is focused on primary school students. What is your target group for this E Plus Life Health Challenge platform? Are you going to expand the group of your target audience in the future? Thank you. I will ask Mr. Hui to answer the question. Thank you, Mr. Look, for the question. Regarding this E Plus Life interface, well, that's not a separate mobile application. In order for us to access the E Plus Life Health Challenge platform, we have to log on to the eHealth application. So why don't we include it under eHealth application? There are several operational considerations. E Plus Life is launched on a pilot basis. Like what Mr. Look said, we work with schools to encourage parents and children to walk more and pay attention to their daily activity level. Students may not be able to log on to eHealth on their own, but the parents may manage their accounts on their behalf. Students may be motivated to accumulate points by walking around the park. Like what Mr. Look said, this E Plus Life should be a core function under eHealth. When we develop E Plus Life further in the future, we may connect it to the application. Some functions may be put under the eHealth application. This is what we're working on. So what is the development direction for E Plus Life? Well, first of all, the Department of Health will make use of the platform to teach a healthy lifestyle. For example, we have a walking challenge and we have a 10,000 steps a day campaign. The Department of Health also have other campaigns on healthy diet and quitting smoking and drinking campaigns and so on. We have different campaigns for different target groups. Second, we also work with the Primary Health Commission, and we also work with the Primary Health District Center for citizens with poor blood sugar and blood pressure levels. We may design an interface for them and so that they can log their data onto the platform for us to monitor. Next, Professor William Wong. Thank you. I have 2 questions regarding AI. We don't have enough doctors. Every 1,000 citizens, we have 2.16 doctors only. The ratio is lower than the mainland and Singapore by 20 to 40%. I know that the government has hired 280 non-locally trained doctors, but we are still having a manpower shortage in the field. In the mainland, they have a Tsinghua AI online hospital. There are 42 AI doctors that can diagnose 300-odd diseases. So I wonder if the administration will consider this idea of AI doctor. If we can use AI doctors that can alleviate our manpower pressure and enhance efficiency of medical services. In the document, it is said that the administration has, in multiple specialties, adopt different projects. Do you have dedicated organizations or teams to assess the AI projects that you have? Under the Hong Kong UST, there is a 4 AI medical models that can provide accurate diagnosis for 30 cancers and illnesses, as well as prognosis for these diseases. Will you incorporate these large models into the daily diagnostic services provided by the hospitals to increase the accuracy and efficiency? Will you make use of local technology more often in the future? Thank you. Chair. Regarding the AI assessment and regulation, I will ask Dr. Cheng to answer that. I'd like to talk about the application of AI in the medical field. Different from other sectors, the risk of medical procedures is very high. Like I said, if we are to use medical devices on a clinical settings, we have to go through 3 different stages and real-world data before we can sell the medical devices on the market. And well, AI is different from medical services, medical devices. They don't go through phase 1 to 3 trials. That's why we have to be more cautious. Second, there's great discussion in the field. Is AI going to replace the doctors, or are they going to complement the doctors? We think that the latter would be what we're going to see. The hospital authority has made use of AI-assisted clinical diagnosis to facilitate the accuracy of medical procedures, especially on imaging. I will ask Dr. Chen to talk about how AI is being applied in the hospitals. Dr. Chen.
I would echo the Undersecretary's comments that we have to be very prudent in the use of AI because, as you know, AI is not a perfect technology, and so we have to understand exactly how it makes its decisions, what are the impact of those decisions on our clinical decisions and so forth, make sure we don't harm our patients inadvertently through the use of this technology. So we are we are moving as fast as we can with AI, actually, with those points in mind. So if I can quickly say that we are doing some large-scale implementations. For instance, we're using AI for screening of hepatitis reports. We're using it for all chest X-rays in the hospital authority are already being analyzed by AI. All of our hip fractures are being analyzed by AI, brain CT images. So there's several of these which are already done at massive scale in the hospital authority. And we're seeing that, the improvements there. Now, the improvements are not that they can replace the doctor. So we haven't got to that stage yet, definitely not. What they're doing is they're helping pointing out things that the doctor may have missed. In other cases, we're looking at, for instance, you mentioned the use of large models. So that's another area where we have to be very careful because you know the problem of hallucinations and so forth. So what we're doing is looking at how can the AI help, for instance, summarize a patient's record, maybe help them draft up a medical report or that sort of thing, and where the doctor is able to, at the end of the day, still review and correct, but it may help them not have to go through everything by themselves. So those are the sorts of use cases we're currently looking at. But I would say that the potential is huge, but we have to be, every one of these use cases has to be carefully looked at and assessed to make sure that we're not causing problems beyond what we were trying to solve. Yes, thank you.
Hey.
Oh, I just want to follow up the question. For the first part of it, because there were proven cases in Tsinghua, so I thought that it may be good to follow up a little bit. And the second part is about the LLM part. I do agree with what you said. The final point that I make is that try to get involved more local research results. I think they're good.
Oh, yes. So we do look at what's happening all over the world. So we look, also, of course, we know in China they're quite advanced at some of these things. So we do review these. Of course, it does need to be seen whether that particular model fits in with what we can do within Hong Kong or the hospital authority. So sometimes they use it in different ways which may not match what we need, or they have different sorts of setup which make those uses possible. So we look at those. We've visited a lot of different centers within China and elsewhere to see how things are working and taking a lot of those ideas back. The last question about working with, yes, we are certainly already speaking to a lot of researchers in Hong Kong and China, actually, to see what we can do in terms of improving large language model use in Hong Kong. Yes, we're looking at that very actively.
即係頭先阿黃錦輝。
That is, as Professor William Wong said, you would look into the application of Tsinghua's research outcomes, or perhaps even modify such outcomes to see if it can be applied in Hong Kong. All right? Mr. Holden Chow. I want to ask about paragraphs 32 to 34 of the paper on telehealth. The Undersecretary may know. All along, I have conveyed to her on a district level, it is very hard to reach the outpatient clinics by phone. Long story short, people are now encouraged to make use of HA Go to make online bookings. And we have been promoting to district users this to make good use of HA Go. But then I note in paragraphs 32 to 34, we have quite good figures. As of October 2024, more than 250,000 teleconsultation cases have been conducted through HA Go. These are pretty good results. So I want to ask, perhaps this is a question for the Undersecretary, what cases are useful to be conducted through teleconsultation? Which cases would require the first consultation to be done face-to-face? Which cases would be suitable for telehealth? If you already know what kinds of cases are suitable for telehealth, then we can tell the residents and they do not have to pour into outpatient clinics. Can the Undersecretary share such information with us? Thank you. Undersecretary. Well, I'll perhaps let Dr. Lee of the Hospital Authority answer this question on telehealth. Thank you. Since we had the pandemic, there had been much advancement in telehealth. We are actively taking forward such services. The patients who are suitable for teleconsultation would be patients who are coming back for further consultations. We consider those having their first consultations should have so done face-to-face. And in fact, for outlying island residents, because it is less convenient for them to seek services from the hospitals in the urban areas of Hong Kong, we would have telehealth services provided to them, but we will take blood samples from them in the outlying island institutions. In fact, when we have the winter service peaks, we would have supporting clinics that can answer inquiries online on allied health. As you may know, say for the body checking services or nutritionist services, these can be done through teleconsultation services as well. Psychiatry and geriatry would also benefit from telehealth services. We have some new functions, that is, one of them would be teletraining. We would have a doctor or a nurse deal with multiple patients. This should help with training. We also have telehealth services for groups, for patients. Whether they are seeking services face-to-face or online, their carers can accompany them online. So these are the various initiatives we have been implementing. Thank you. It's now my turn to speak. I'm very glad to hear that in the first quarter of next year, we will be amending legislation to promote health record sharing. It was as early as 2005 that an alliance was set up to promote electronic health record sharing. We did see very early on the difficulty would lie in encouraging private healthcare professionals to share electronic health records with the government. Unfortunately, we now see that there is no other way than amending legislation to do that. Mr. Duncan Chu said the hospital authority has been making good use of technologies. I'm most happy about the hospital authority reforming their systems and institutions, not only for the sake of employing technologies, but to benefit patients. In future, whether we are using AI, telehealth, or low-altitude economy applications, we are just trying to bring more convenience to patients. We do see a chronic manpower shortage in the healthcare sector. As other members said, we should perhaps make good use of AI to alleviate the problem of manpower shortage. On cross-boundary healthcare collaboration, we do see a greater demand for health record sharing between the two sides. We have seen more elderly persons aging in the mainland cities of the Greater Bay Area, or even locals. We may seek treatment in the mainland due to the high costs of such in Hong Kong. I didn't see the paper mention aspects relating to Chinese medicine and Chinese herbs. I want to ask, because this is one of the major directions to take, what is your development direction in this area? Some patients' organizations have been advocating for the introduction of drugs, especially drugs for cancer and rare diseases. It has been expedited, but then I feel like there is still room for further streamlining and enhancement. Is it possible that we can make use of AI or other technologies to expedite the introduction of drugs? Thank you. Undersecretary. I would like to thank Ms. Kuo for your continued support to promote smart health. I'll let Mr. He answer the question about the transformation of Chinese medicine and herbs, and then I'll answer the question on the introduction of drugs. Thank you. Thank you. Chinese medicine is an important part of the healthcare system. We do not see many Chinese medicine practitioners making use of e-health. And one major reason is that Chinese medicine records are often still on paper as well as not standardized. We hope that with the commissioning of the Chinese Medicine Hospital and the digitalization of the workflow of Chinese medicine, it can act as a reference for digitalization of the Chinese medicine sector in Hong Kong. We do have the Chinese Medicine Testing Institute in future, and we should be able to promote standardization. And this is the direction that we are going to take. And this will lay the foundations for us to promote smart Chinese medicine. And for clinical applications, at the end of last year, we will test those after the commissioning of the Chinese Medicine Hospital. I have a follow-up question. You are saying that Chinese medicine records are not very standardized. That's why it's hard to digitalize the records. But I have visited many Chinese medicine clinics and institutions in the mainland. It seems that they have already standardized the format of records. Would you refer to examples in the mainland or the digitalization standards to see if they can be applied in Hong Kong? Mr. Ho, thank you. Well, I think there is a difference between the clinical settings in the mainland and Hong Kong in terms of Chinese medicine. We are trying to help mainland Chinese medicine to go global, and Hong Kong will act as a springboard for that. In terms of Chinese medicine development, Hong Kong plays a special role while trying to make a contribution to the country's Chinese medicine going global, especially with the complementary use of Chinese and Western medicine. Hong Kong has good foundations to make contributions to the development of Chinese medicine in the mainland and such going global. So while we are trying to work with mainland China, we think Hong Kong will play a special role. All right, I have great expectations for that on the Secretary. Thank you. We have reformed the 1+ evaluation mechanism. So as long as the drug is certified by one place, it will be accepted to be used in Hong Kong. So that will enhance affordability of drugs because there are more options now. It is also, of course, faster when making drugs available. We also have now a database. For example, the hospital authority has a diabetes prevention model. They can make use of big data to do a triage system to identify high-risk diabetes patients to see if they need to take some drugs to minimize risks. And this has attracted some pharmaceutical companies to do research in Hong Kong. And I think we can make good use of the advantages of the Greater Bay Area, with Hong Kong being a data hub, to attract pharmaceutical companies to Hong Kong to realize R&D outcomes in medicine. This is an opening up of not only the Hong Kong healthcare sector, but also the healthcare sector in the mainland. This measure of the current term government will definitely enhance quality of services in the healthcare sector in Hong Kong. Thank you.
多謝主席。
Mr. Chan Xiu-hong for the second round. Thank you, Chair. I'd like to follow up on two subjects. First, telehealth and going paperless. Now, in the administration reply, it is said that we have 250,000 cases under for telehealth under e-health. We want to facilitate people living in the remote outlying islands and people with physical impairment to consult a doctor. Telehealth can alleviate the pressure of the public hospital. But can we be more aggressive? Among my friends, or the Sham Shui Po district that I serve, I don't think that a lot of them have joined the telehealth program. Every 3 to 4 months, they have to go for consultations. And some of them work, and they have to go to clinics or hospitals that are far away from where they live, and they have to spend 1 to 2 hours to queue to see a doctor, and then the consultation lasts usually 2 to 3 minutes, and then they have to queue another 30 minutes to get their drugs and medication. You choose patients with stable conditions and clear diagnosis, as well as those who upload their medical metrics regularly to participate in the program. Currently, patients can only participate in telehealth upon invitation by the hospital authority. For patients who want to use telehealth service, they cannot do so. Now, on social cost, telehealth service will lower it. Second, when we visited the Chinkono Hospital, I know that they're trying to go paperless, but some carers of the patients want to get a physical consultation paper or medical prescriptions. But a lot of other people want electronic records. On the HA Go, we can access the list of drugs, the reservation situation. Is there an opt-out option? I think that there is room for improvement. Thank you. Let me first answer the question on telehealth, and then for paperless, I will ask Dr. Chen to answer that question. The problem raised by Mr. Chang may not be solved by telehealth. For people who are working and have stable conditions, do they have to stay in the public hospital systems? Can they go for consultations with family doctors? There are many ways for us to deal with the problem. Maybe they can go for nurse clinics to obtain medication because their conditions are stable. Telehealth may seem convenient for members of the public and may lower the social cost, but medical practitioners have to set up a room and additional manpower is involved in the provision of telehealth services. there are various ways for us to deal with the case that you just mentioned. We do not have to rely on telehealth. Undersecretary, can you be more concrete about what other options that patient has that will facilitate their consultation? I know that there are nurse clinics for consultations. Patients don't have to come back every 3 months. Maybe they can go see the doctor once a year, and in the meantime, they can see a nurse instead and get their medications. There is not a functions on HA Go for nurse clinics. I will look into how we can provide a more personalized service under the hospital authorities for patient in need. I will ask Dr. Chen to take the other question.
Going paperless is certainly one big benefit of all of the smart hospital initiatives that we have. So I can share with you, for instance, in the inpatient medication system, we've saved millions of pieces of paper over the few years. Just in the last few years, we've saved a lot of, just in the recording of people's blood pressures in the ward, that's already another million pieces of paper. So that's something we're certainly moving with. Now, in terms of the patient themselves, when we started the whole HA Go, we were thinking about, let's reduce the amount of paper we're printing at the outpatients. Now, the trouble is we found that most patients still wanted the paper. They weren't quite willing to give up the paper, even though it was also an HA Go. They still wanted the paper. So I think we're in a transition stage where we're now a lot of this information is available on HA Go already, but we're still printing the paper because most patients still want a copy, still like the physical copy. Now, but as I said, I think we're in a transition stage, and I think over we can certainly investigate whether we can move that timetable faster, or as you've mentioned, the idea that could some patients say yes, opt out entirely.
Opt out.
I think we can look at that.
Option.
Yeah, that's an idea we can certainly explore.
Good.
Thank you.
All right, thank you.
No other member want to speak? That concludes our item 1 on the agenda. Item 2, any other business. The next meeting will be held on the 16th of December 2024, 2:30 to 4:30 p.m. The administration proposes to discuss regional collaboration on smart city development. Members, do you agree to discuss the item? If there's no comment, then we are going to discuss it in the next meeting. There being no other business, meeting adjourned. Thank you.